Okay, so good evening, dobre, to everyone out there. So first of all, I want to thank the OHIS organization for this nice opportunity that I have to share my experience and knowledge within this webinar that I hope will be interesting for all of you. It has been asked to me to cover one of the most hottest topic currently, which is represented by class 2 malocclusion and how to handle them with a hybrid option in adults, teenagers, and teen and kids. So this reminds me always of with this picture about hybrid that became very popular in the last decade, and now from gas to hybrid, and now electric became the new trend in cars. So you will see some comparison within my talk about this aspect about hybrid. So just to give you a small introduction about myself, about my experience, my background, I have an MD degree. I'm an orthodontic specialist. I have the European Board of Orthodontic Examination certification. I'm a past president of the European Aligner Society, and I have a practice in Torino, Northwest Italy, which is dedicated exclusively in orthodontics. And our practice now, since some years, is fully, entirely digitally driven. So just to give you a small view about my city, so where do I live and where do I practice? This is a view of Torino, which is located northwest Italy, close to Milan, about 120 kilometers from Milan. As you can see, is surrounded by the Alps. And you can see this is the city where we have a river, the Po River. A nice tower is represented by the first capital of Italy. You can see there are churches, historical walking areas, and a lot of green where you can run. And the strip where all the shopping center is. This is San Carlo Square, and this is the Superga Church, which was a church of the kingdom. And this is the dome where the Holy Shroud is located. And for Christians, is a very important place. This is the Royal Castle of Torino, where the king was going to the countryside, and Torino is very famous for the church. This is again the Superga Tower, the Superga Church, and this is a view of Torino overnight. There are a lot of museum. Probably you know better than me, Milan, Rome, and Florence, but I would say that Torino is the underdog among the cities in Italy. And this is like a time lapse of the city, which is like a sleeping city, looks like sleeping city, but is a very strategical because we are 1 hour from the Alps, 1 hour from the sea, 1 hour from the lake. And this is the view where I live, so very close to the city center in the pre-hills, and you can see how the city is going down and sleep quickly. And so this is just was a view of our city, which I'm very proud of being here. And before I start, I just wanted to about the topic. I just wanted to give you a walkthrough my orthodontic clinic that I share with my father, who is also an orthodontist, and with whom I'm sharing every day experience and knowledge about how we can improve and make better our experience in daily practice. These are 4 screenshots of our practice where, as you can see from the upper left corner, our consultation room and first visit room, where already we have dedicated a lot of technology with an intraoral scanner, a cone beam machine, a consultation area with 2 large screens when we're sharing treatment plan with the patient. We do our diagnostic and consultation. The upper right picture is the second consultation room where we discussing treatment plan also with the patient, or we sharing through pictures and images the in progress of the treatment plan. The lower left picture is showing you the open space where we have the three chairs where usually kids and teenagers are sitting down. And now, due to the COVID-19, we don't have the computer at the chair side to reduce the social distance with the patient. And there is also another room with dedicated to adult patient, where mainly we're looking at adult patient. So we tend to also to create an environment very friendly with art also inside, where we have to enjoy all the day. This is brings me to one of the reason why the topic of this presentation is coming from. So about the expectation that the Gen Z, the Generation Z patient are having today. So the Gen Z represent are people who born between 1996 and 2012, um, uh, where this category of people will represent the more than 40% of the customers in our practices. They're people who already made a volunteer experience. They're more worried about the planet than business, and they made already some donation, and they are involved in charity, and they thinking about a lot about the future. And three main aspects that this Gen Z patient have are three main aspects. So, which are treatment within 12 months, ideally, a minimally invasive orthodontic experience, but also a reduced need for compliance. And we know that the treatment with aligners, for example, which I do a lot in my practice since being an, let's say, consider an expert since 20 years when I started in 2001, we know that there is a treatment where you need a lot of compliance. So these three aspects I have to keep it in mind whenever I have a patient is sitting on the chair side, and especially for those one asking for an aligner treatment. And it is important to know some important points about what can be done in class 2 malocclusion non-extraction in aligners in 2021. And this is an article published back in 2017 with my good friend Tommaso Castrofloro, who I know also lectured at this organization. And so this was an updated systematic review regarding the efficiency and efficiency. So we know that the upper molar distalization up to 2.5 millimeter is one of the most predictable movement that we can obtain with clear aligner therapy. But this was obtained through the combination of three aspects. The first is staging, and staging is one of the most fundamental thing we have to look at when we're working with virtual simulations. So a distalization protocol of molars, bicuspid, and canine by 50%, which is the one a protocol that we commonly use in our conventional brackets and wire system. The second main aspect is the use of optimized attachment on all the stylizing teeth. And if you don't find optimized attachment, then you have at least need to have non-optimized attachment present on these teeth to make sure you have a good control of molar, bicuspid, and canine with a bodily distalization. And the third aspect is represented by the use of class 2 elastics, which is one of the aspects that some people can forget that treating patient with aligners, they don't need to use elastics, but the biomechanical rules are the same. We're using a different tool, but the principles are the same in biomechanics. And in 2016, together with Tommaso Castrofloro, Sam Dyer, who's another great aligner expert, and the Torino group at the university, we made a study on the efficiency and effectiveness of composite attachment in controlling the upper molar movement with aligners. And we found out that with 5 attachment, we had a bodily movement of the second molar, the first molar in central incisor, and the bodily movement of the second molar increased by 165% at the center of the crown and by 230% at the apex of the palatal root. While with 3 attachment configurations, so not on all teeth that we need to distalize, the performance was a little bit lower than this. Um, and in terms of class 2 treatment and guidelines, do we have guidelines? Of course, we have great guidelines, simple guidelines given by these two giants in orthodontics who are Jim McNamara and Bobby Ricketts. And both McNamara and Ricketts is telling us two very simple things, that by the effect of the derotation of an upper molar, which is very often present in class 2 malocclusion, we gain in space. Space needed to then move distally bicuspid and canine. And the other macro rule that we have as a guideline is the Ricketts rule on how the upper first molar should be positioned in comparison to the opposing upper canine. So these two fundamental aspects are something that I always keep in mind whenever I have to deal with with the sagittal correction. So before distalizing first, I need to derotate first upright and then distalize molars. So in that sense, many class 2 malocclusion, non-extraction, what you want to correct by distalization, can be fixed by the sequence of these three movements. And we know that by in derotating molars, the etiology of the class 2 dental malocclusion, we know that the first maxillary molars rotate mesially and palatally within the space left by the second deciduous molar. And some studies by Henry, for example, published back in 56, demonstrated that 83% of patients with malocclusion show a mesial rotation of the upper first permanent molars. So one rule that we never have to forget is that at every action corresponds a reaction equal and opposite. And today, especially when we're dealing with sagittal correction, we cannot think or believe that plastic cannot fulfill some specific rules that we all already have with brackets and wires. And today, in this century, we have studies like technologies like finite element analysis that allows us to control and to study the effect of the action, but also the effect of the reaction. So in that sense, once we're dealing with class 2, we have to think about option. It's important to know about option we have. Do we have only one option, or we have 4 options, like option 1, option 2, option 3, option 4? For example, if we have a class 2, and that's depending on our experience or the diagnosis, we have to do carefully. We can decide to have a first plan with a distalization, a second plan with an extraction, a third plan could be a surgical option, and a fourth plan could be, for example, the use of elastics. So which appliances can be used with this hybrid approach? And that's the topic of the talk tonight. There could be many appliances. Think about the appliance you use in your practice for correcting class 2 when you want to speed up a specific goal of the malocclusion, which is class 2. Could be a pendulum, could be a distal jet, could be a motion carrier, previously called distalizer, or every other class 2 corrector. So having this in mind, which can be the appliance used with this approach? And the two questions I have to ask myself, and I asked it myself years ago, was why and when a hybrid? The why and when was related to some question I asked myself was, can I have something that could reduce the complexity of a single movement, which is the sagittal correction of molar and canine? Could I optimize the treatment time? Could I reduce the compliance issue, which are three aspects that I have to consider whenever I have to deal in class 2 correction? And so thinking hybrid is like thinking about years ago a Lamborghini or a Ferrari hybrid. That could be considered like to be a devil in the church because the fanatic of the supercar sure think gas. Now you can see already going also Porsche going to full electric. So the reason why of gaining hybrid is also due to the fact that we have to think about our patient. We can do the most performant plan in virtual, but we need also to think about patient compliance. And we have technology today, like the smart cases, that allows us to control, to check the compliance of the patient by how much time they leave in the aligners in those cases. So making the reverse action of a simple aligner case that we get from every aligner manufacturer, but we don't know exactly how compliant will be the patient. So today with those kind of cases, with an app, we can know for how long the patient is wearing or not wearing his aligners. And this allows us to track, remind, and find, and this is like a schema of one of my patients with whom I could check he's compliant. So in terms of hybrid solution, I will focus on explaining you how I'm dealing in the last 6 years using a hybrid approach using this device. As you can see, the device it's quite simple. And sometimes it's too simple to be, I would say, real. As you can see, is like an arm that replicate the articulation of the hip. So you have you have an arm that allows you to derotate the molar. So it's like an articulation that you bond on the molar, you bond on a canine, and the first two actions that are performed are derotation, uprighting, followed then by the sagittal correction. One of the main key is that I always tell also to my patient that the arm itself, without activation, does nothing unless it is activated by the patient. So this is something that has to be clear also for the patient, that they have to do their job to come to the final outcome. And 6 years ago, I wore my student hat back, and I flew to Barcelona, where I met two great orthodontists, Pepe Carrier and Luis Carrier, two very passionate orthodontists, which has something in common with me, my dad. And in fact, Luis' dad and my dad are both members of the Anglo Society of Europe, so they have the opportunity to spend 20 more years at that society. So I and Luis were able to enjoy orthodontics from our fathers. But then we became passionate both in technology and different way of dealing orthodontics. So I went back to Barcelona to learn and understand how this device looks quite simple or simplistic, could be efficient and effective in controlling this specific task of a malocclusion. So there are two key aspects within the Motion 3D appliance that I will highlight on the effect. So the key aspect is represented by the hinge molar for uprighting and molar derotation. And the second aspect is represented by elastic protocol. So as you can see here, there is one part of the device, which is the canine pad, where the patient has to wear an elastic. And the second one is the molar pad, where mainly the action is transferred, and this allows to control the first two steps of the correction, which is represented by derotation and uprighting of the upper first molar. And on the typodome picture, you can see pre-treatment and after treatment, you can see that there are some natural effect related to this action activated by a specific protocol of elastics. So before and after this first step of the treatment, you will see derotation, space creation mesial to the upper canines. That will be then followed by the action of either a fixal appliance, either aligners to close the upper spaces. And already Arnold Stoller back in 1954 at the American Journal of Orthodontics was highlighting the importance of the position of the upper first molar and the interdigitation with the lower. So the second aspect of this approach with the Motion 3D appliance is then represented by the elastic protocol. And this elastic protocol forecasts the use of two types of elastics. The first one is named Force 1, which has the following side of 146 ounces, worn by the patient for the first month of treatment. And then there is a second type of elastics named Force 2, which has the following side of 316 8 ounces, which has to be used by the patient from the second month until the class 1 is reached. And in that sense, I want to be very clear that I don't like to follow any commercial trend or say, okay, within 6 months or 4 months, this will be done. No, I tell the patient that I will remove that arm, that Motion 3D, once we get to the goal. So on having the full class 1 in position. And one key aspect is to tell our patient to change elastic 3 times per day to make sure that the elastic force is always consistent. I never leave the patient with the same elastic for the same day. I want to have the patient changing elastic every 3-4 hours. So making sure that the same consistent force is following all over the time, because the equation should be also for the patient. As long as you wear elastics, as consistent as you are, as earlier I will be able to remove that auxiliary appliance from your mouth. There are different protocol of elastics, and you will see on our following slide that not all elastics are the same. And it's not me telling you this, but one great orthodontist who may study about this. So there are different protocols on the elastic protocol. That could be the conventional, the standard one, where you're bonding two motion, left and right, or single one, and you're having a button placed on the second molar, and then you have the first month, the force one elastic, followed by the force two elastic until you get to a class one. The second configuration, if you have, for example, the second molar not fully erupted, then you can go with the motion from canine to first molar, and then having the two buttons bonded on the lower first molar, and using the same protocol for the first month and from the second month until you get to a class 1. There is a second solution because there can be different scenario of class 2 malocclusion. For example, very often having a blocked out canine protocol, so where you don't want that you cannot bond this device on the canine which is blocked out, but you need to create space to allow then a following bonding of let's say action on the canine. So you make a motion, a short motion from upper first bicuspid to the first molar, a tube on the second molar, and then the same protocol of elastics. So first month, force one elastic, and then from the second month, force two elastics until you get the space. The third solution can happen and can occur when you're dealing with the adult patient with a high bone density. And this would be a case among the cases that we shared with you where I was using this kind of approach. So in that sense, in those cases, you can have the configuration of motion on upper canine, first molars, and lower either second molar if you have room, either first molar if you don't have room, and for a few months, asking the patient to wear a double force to elastic, but for a limited amount of time because you can see there are heavy forces. So you can wear it for a couple of months at nighttime just to counteract the scenario where you have high bone density. And there is a fourth solution in elastic protocol where you can use this kind of approach in mixed dentition, so with the decidus canine. If you have those scenarios, it's very important that if you bond on a decidus canine, you have at least 50% of the root of the decidus canine present. Otherwise, you have to wait and see. So in those cases, the amount of force used has to be lower. So using bonding, yes, a motion on the decidus canine and the upper first molar, and having a force one elastic only for the whole treatment time. So not using force two elastic, which is too excessive as a force on those young patients. So I was telling you that not all elastic are the same. And for that, I will just show you a slide from a measurement that Jim McNamara did just to investigate if all elastic were the same. And what he found out, and his team as Ann Arbor, were that these elastics, the force one, as you can see there, for 5 type of elastic studied, and the force one HSO carrier elastic was expressed in 340 grams, while the second force two was expressing 600 grams, while another American orthodontics elastic was less, let's say, powerful as elastic. And this brings me also always give good respect to Jim McNamara, who is always, let's say, behaving as a young student, despite he could just live on all the things that he wrote and published in the last 40 years. So for the elastic anchorage, you can use either a button or other devices. So for example, a good point where you're dealing with buttons is that you don't need to increase the width of the button cutout on a lower aligners if you're using aligners. So in fact, that button cutout are made, for example, with the Invisalign. It's made for buttons, not for buccal tubes. And at the beginning of my experience, I didn't have those kind of buttons. So this kind of button is named Sidekick and allows you to have this distal wing very easy to handle for the patient to have him or her wearing this force 1 and force 2 elastic, because it's also important to consider the patient experience when you need to have a patient wearing those elastics. So easy for the patient, easy for you, and the bonding base is made in a way that the possibility of having bone failures is very seldom. So as you can see, these are the picture of a patient with the motion clear in this case, and the elastic placed on. And these are kind of pictures that are always sending to the patient. Just as a reminder, I also encourage them to do a picture with their cell phone to have a reminder in how they have to wear these elastics. It's important. We spoke about the devices, so the motion. We spoke about the elastic, the different type of elastic that can be used, the different protocols. But it's important in that sense to create, to have as an anchorage the mandibular arch. So we need to have a solid and consistent source of anchorage in the lower arch to avoid what? To avoid the protrusion of lower incisor, which can happen and happened in the past when Luis Carriera spoke with me about his experience many years ago, I would say 10 years ago, when he was using a lingual arch. But as you know, a lingual arch has no control on the lower incisor. And if you're using such forces with a lingual arch without any control, which is a risk that you have flaring of the lower incisor, so no control. So I just wanted to share with you four options as a possible source of anchorage, which could be Essex retainer, lingual arch, braces, or aligners. I will focus on aligners because that's a typical trend now I'm using in my practice, because also the request that the demand of patient to be treated with aligners is exploded in the last 5 to 10 years. So what I like about this rationale is that instead of having an Essex, which is a passive aligner without any control on the roots of the lower incisor, with the aligners and certain type of aligners you can have power ridges to control the torque, you can already have an action, an active action of these lower incisors. Considering that in many class 2 malocclusions, especially in class 2 division 2, we have crowding to handle in the lower arch. So it can be a win-win scenario to use, for example, aligners at the beginning to unravel some crowding while we're working on the sagittal in the upper arch. So to activate the device, what you need to do, I just trying to put you in my practice on a different scenario. You could place either a lower Essex, you could place an initial aligner, you could have lower brackets with a wire, and then attach the elastic at the second and the lower second or first molar tube, and stretch to the hook to the maxillary cuspid pad with a small instrument, or as how patient does the most of the time to use their two fingers. And I refer to the elastic protocol. As I showed you before, you can have different protocols. The most used at the beginning is the first one, where you have motion, sidekick on the lower second molar, and then force one for the first month, and then force to elastic from the second month until you have the class 1 canine and molar reached. So in terms of appliance selection, there is always a question on, Francesco, what kind of appliance I have, what measure I have to select. So, and for example, when I have the distance measured with a ruler, as you can see, there are specific rulers that allows you to space to position the device with a molar pad in between the two molar cusp and the canine pad in between of the long axis of the canine. So typically what I do, I take this measurement before the bonding session. So in that sense, I don't need to have a long inventory of those hybrid devices. So once the patients come after a couple of weeks, when I deliver the first aligner, I already have the motion appliance ready to be bonded on the patient tooth. So if I need more molar rotation, I will select a smaller side. And if I need a less molar rotation, I will go with a larger side. And that's another question that many times my colleagues ask me, oh, but which are the most used measure in your practice? I can tell you that when 6 years ago I started to use it, I asked it to Luis, can you tell me which are the most used measure? And he told me 23, 25, 27 as a regular, and as a short 16, 18, 20. And I can tell you that after 6 years is exactly what I have. So having these boxes, I see that I always have at least the two, as you can see, 16 left and right, 18 left and right, 20 left and right. I always want to have two couple each to always make sure I don't run out of these measures. So there are some key points important on placement, alignment, and curing. So for placement, the inventor, who is mainly Luis Carrier, uh, and and as always, the small things makes the difference. Details make the difference. So he invented this specific tweezer, which is very useful to grip it because it has a small indent inside the tip. So allows me to, once I prepare the tooth, then what I do, I just prepare and bond etch the two teeth, and then I put my bonding material, and then I place it first the molar pad, and then the cuspid pad into the mesial of the canine. And there are vertical groove on the molar pad that allow me to make sure I have a reference on how to place it. One very important thing is to make sure that when you position the device to align both pads as parallel as possible to the occlusal plane. So if these two teeth are not at the same level, is for example in the case of a blacked out canine, never make the mistake of bonding the device tilted. Otherwise, the risk is that you will only extrude the canine with the risk of gingival recession, and then cure it. There are some bonding tips, especially when you're using the clear one, which is dedicated to adult patients mainly, but also a mature teenager are asking for something clear, despite we're living in a COVID-19 era where everybody's wearing masks. But some bonding tips are represented by removing excess adhesive while maintaining the alignment of the device. Fully cure the molar pad first, and what I do, I put some excess of composite on the canine pad, on the, as you can see, on the initial part of the arm, to make sure to have a very consistent and solid arm with a less risk of debonding. And then I cure the cuspid pad. Um, as a general thought, when I 6 years ago I first was looking at this principle, so which is named sagittal first, uh, and I thought, could I embed this approach with aligner treatment? And I remember one of the first slides I show you about what can I do with aligners in sagittal. 2.5 millimeter, the literature is telling us that is the maximum amount predictable. Of course, I can get with a 4 millimeter sagittal correction, but I can also I have to think in mind that I also need to consider the derotation and the uprighting, which are two movements which are embedded in the sagittal correction. What I like about this teamwork is that I didn't need a lab. It allowed me to have a direct bonding. It was forecasting the bonding only three teeth, so upper canine, upper first molar, and lower molar, and that the device was very high tech and discrete, so perfectly embeddable with aligners. So this kind of approach remind me, and you know, in Italy, we're a country where we love sailing, and Luna Rossa just lost the Prada Cup with against New Zealand, they chapeau to New Zealand, where on this boat, everyone know to do. You have the tactic, you have the trimmer, you have the grinder, you have the shipman. So everyone know to do. So in order to make sure you win the race, you need to have, yes, of course, a very nice boat, but you need also to have everyone in the team knowing exactly what to do. And so one of the questions I had at the beginning was which kind of treatment sequence I should select. Should I go sagittal in the upper, transversal in the lower? Could be this better together? And I already anticipate one question that many of you will tell me, yes, but Francesco, we are used to do transversal first, sagittal, and then vertical. But I don't think we have to behave with dogma in our profession. So that's the nice of our profession also to to change the rules, but having a win-win scenario. Because if I have to think that in class two, if I expand first, if I need to expand, and then after some months, I have to ask my patient to wear elastics and to distalize, I will burn the first 6 months, which we know is the first period of the treatment where we can ask whatever we want to a patient. But we know that after 6 months, the level of attention is reducing. So within 6 to 10 months, you need to let's say to be very active in reinforcing the motivation. After a year, those kind of patients can lose some confidence. So then you can get some issues. So this kind of sequence could um, be better because they can optimize timing and increase efficiency to create a really win-win scenario. So one of the questions that many colleagues ask me, okay, Francesco, I got the point. We have here a device which could be the motion, but could be whatever, could be a pendulum, could be a distal jet, whatever kind of class 2 corrector. But how could I fit this into the aligner treatment where we have to make a prescription, we have to make our plan, and we have aligner upper and lower? How can I let the technicians know that I'm using something else in the upper arch? So the first aspect I recommend is, and we know that in orthodontics, is all about strategy and planning. So we know that my mentors told me, Francesco, if you do a good planning, do diagnosis is already 70% of the treatment. And the rest is the appliance and your patient. So what I recommend is, if using Invisalign, for example, is to ask first a clean check plan with aligners only. And once you get the first clean check plan, evaluate the length of treatment, the predictability of the class 2 correction, which is for me a key point, but also potential compliance issue. And then once you get the first clean check plan, ask for a hybrid solution through a diagnostic setup in the upper arch. So, and I will show you how you can ask this to a technician once you get the first clean check plan. Because if I don't have my first plan with aligners only, then I don't know if they would be too long, if it will be predictable or not, because we need to make sure that that virtual plan is predictable. And for me, predictability is one of the key points that I would always want to have addressed. So other question that I had, and I hope that also you can have now already after this half an hour, but when I could use this kind of approach of sagittal first. I just show you some examples that you will see later on of unilateral class 2, bilateral class 2, in full dentition, in a mixed dentition, both late and also early. And we know that in clinical cases, I just want to show we have a different scenarios that we can handle, like adults, like teenagers, and like kids. So imagine that Homer and Margie need an orthodontic treatment, but then also you have Bart and Maggie have need a treatment, and then you also have not the baby because the baby is still too young. But I just want to start with you with one case of an adult patient. Gabriele came to our practice, 20 years old, class 2 dental, class 1 skeletal with crowding. And before treatment, as you can see, he got an amount of class 2 quite important, with the presence of the molars, with some crowding. And his main concern was not the class 2 because he didn't even know that he has a class 2. His main concern was the upper canines, which were too buccally displaced and a little bit of crowding. So the diagnostic summary was confirming us that Gabriele was a class 2 skeletal with a class 2 molar relationship, with a retrusive mandible. The panoramic X-ray was showing us an implant on the 36, third molars, both in the upper and the lower. So the strategy for him forecasted the class 2 correction molar and canine, non-extraction solution, and you will see we went for a hybrid solution, but only once we got the first virtual plan, which was not hybrid. And in the meantime, we started to correct the lower crowding. And since he didn't have nice teeth, he was also planning with a referring dentist to make a restorative finalization on the upper anterior segment. So this is the first clean check plan. What as you can see, we had 68 aligners that was planning a plan of movement, nice but long. So not everybody is ready to be long, predictable, because that has to be clear that this plan was predictable. But thinking that a patient, an adult patient who liked a lot nightlife in Torino and bars and cafe, more than working, it could be really risky. And so as you can see, we have all movement, fully predictable, some complex movement, but my main concern was his potentiality of compliance. And so that's why I asked two plans that I afterward have to share with him during the consultation appointment. So what do I ask to get the following hybrid solution? So once I get the first virtual plan, I click it on ask for modification, and I wrote to the technician the following. Please show me a diagnostic setup in the upper arch where you show me in one stage movements that I will perform with another appliance. Thank you. So these 4 sentences was very important to let the technician understand what I would like to see in the virtual world in the next CleanCheck plan. So I send this modification, and then in a couple of days, I get the second CleanCheck plan where you can see in one step they changed the sagittal that I knew that I could handle with a hybrid approach while I already starting working with aligners in the lower with some attachment, both optimized, not optimized attachment, and with precision cuts that allows me to bond buttons on the lower second molars to allow the patient wearing elastics. So what I did, I shared him with the plan, both the first and the second, and he was very honest. I say, I'm not ready to wear elastic for a year and a half, which was the plan for the first. He appreciated that I explained him that the plan A, plan B, but he said, Dr. Garino, I'm more prone to go for the second plan because that step would be shorter for me in terms of compliance. So I went through the use of Motion 3D, clear one, of course, both sides, aligners in the lower. For the first month, force 1 elastics, and from the second until we got to a class 1, force 2 elastics. Then with the bond and the motion, we made impression for an upper temporary elastic retainer to freeze the scenario until, and then I made at the same appointment a scan for new aligners to complete the treatment. So this is how we started in the upper arch, where you can see the arms on both sides. And of course, I told him, look, if you don't wearing elastics, this scenario will be like this in the next month. So it's all up to you to activate this device to make sure we get to the final point. So as you can see, he was in progress. At the beginning, he was not that aggressive on using elastics, but when he understood that he was using that procedure, changing elastic every 3 days, you see we got some spacing, which is not a side effect, but it's a natural consequence of this derotation, uprighting, and translation of these teeth, coming to a scenario which was quite different from the beginning. One of the clinical tips that I want to share with you with this case is that when you have those kind of patients with a high bone density and that after 4 or 5 months you still don't see too much movement, you can ask him or her to wear only at night for a limited amount of time double elastics, double force 2 elastics. So Gabriele, at this point with the bond on the device, I could have overcorrected this position, but he was honestly, he was looking for aligners at this point. So I did not overcorrect it as I could have done. But already was a good change from the beginning. So with the bond and the motion, and these are the comparison of beginning, in progress, and at the end of the sagittal first phase, where we not only corrected the sagittal, we improved the transversal, and we improved also the vertical. So the swap to aligners went through these stages. So with the bond and motion, we made an intraoral scan, we cut the virtual model base with a software tool, and then we submit the scan, and it took for the scan 1 minute and 30 seconds for me, and they export the STL file from the cloud. And then he went with the 3D printing process that we have in the office in 6 years now. So we selected the CSTL file, sent the Wi-Fi to the printer, and within an hour and a half, we got a resin model on which we could manufacture a temporary ASIC retainer that to be worn by the patient day and night until I got the new aligners of the upper and of the lower arch. And this is just a small video on it showing you how can be the live process for 3D printing that I do, but also my staff does. So once I done the model, the scan, within 5 minutes, I can just export from a private area that all iTero user has, the upper and lower model, and then I can cut the model just to reduce the amount of resin to be printed. And then after really 2 minutes, I send this Wi-Fi to the printer, and within that time, I'm ready to deliver these to the patient. So one of the other clinical tips is to provide always to the patient a standby bite. Once they bonded the hybrid um, appliance, which could be this one, but could be also uh, uh, um, a distal jet or whatever kind of a pendulum that you can use. And it's important to be that this is delivered within a day, maximum two, no later, because I want to freeze the scenario until I get the new aligners to complete the treatment. So this is how he was from the beginning to the end of the first step of the treatment. And this is the clean check plan that we had once in the meantime, and it took a couple of weeks to have the new aligners. So during this additional aligner stage, we had 23 upper aligners. We have 6 aligners in the lower. And the main goal here was to work on the rotation of the canine, close all the spaces, and work on the bicuspid in the upper and the lower arch. So getting to this final outcome, that should be his final outcome before going to restoration. So that's him in progress, where you can see that the spaces are closing in, and in that sense, having aligners were very helpful because they were hiding some spaces between teeth and teeth. So this was him in progress, and you see that the spaces are progressing, the bisetting is improving. And then he went to my colleague, general practitioner, Dr. Paglieri, for making a mock-up to restore his teeth. And that's him before and after mock-up. So I let the ball to my colleague. So once the mock-up was done, and then once the crown was done, then he came back to the office then to do a scan for final retainers. And that's him at the end of treatment. As you can see, we corrected the sagittal, we corrected the transversal, we improved the vertical with the midline centered, a class 1 molar and class 1 canine on both sides. And as you can see here in this case, we asked him to extract the upper third molars at the beginning of treatment, and most likely he will be asked to extract the lower third molars during retention. An important aspect about the use of these elastics that was a guessing point at the beginning of my experience was, but this elastic will procline too much my lower incisors. Only 2.9 degrees of proclination, considering that we use elastic for more than 7 months. But if I look at the comparison before and after, with I will say a limited invasive orthodontic approach, we were able to fully control the sagittal, to improve the vertical and the transversal, with the good work of both the orthodontist but also by the prosthodontist, and getting to the ideal scenario that we're aiming for. And even more important was to check after 2 years of retention how he was totally stable during his retention time, that he's running with his Vivera retainers. And so that's a story about Gabriele, which lasted 7 months with his hybrid approach, so motion appliance and aligners in the lower, followed by 6 months of additional aligners, changing an aligner every week, and for a total treatment time of 13 months. And what's the current evidence of this kind of approach? And it's not my evidence, but it's someone much more important than me, who is still McNamara and Frankie, that published both in 2017. They studied all the cases of Dr. Carrier, of the Carrier practice, to see which were the effects that could happen. So there were no distalization of maxilla, so there is no skeletal effect, and that there is no either a claim about this. They found out a distalization of the maxillary posterior teeth, but also a mesial movement of the mandibular teeth. One of the most important aspects that they found out was opening of the occlusal plan, especially at the end of the first step. And in 2019, Jim McNamara lectured at Yale annual session in a packed room. I remember I was there as a follow-up of this preliminary job. And this second article was published then in 2019, and you can find this on the Angle Orthodontist, which is an open access journal. that mainly they found out that from the T1 start of treatment, T2 end of the first cell of the sagittal correction, the average time was 5 months, plus minus 2.8. So in average, you have to consider that the sagittal is one of the part of the treatment. So you will see that also later on in teenagers and kids, as this time could be shorter because we're dealing with a different bone density. The second case I want to share with you as an adult patient is Julia. Julia was one of the biggest nightmare I had in my office when she came in the office and then she opened the mouth because 30 years old, class 2 dental skeletal with severe crowding and open bite. When she came to the office, that was really a nightmare for me, potential nightmare. But I wanted to transform her the Black Death in Millennium Falcon, I will say, because when she came, 30 years old, nice lady, she got an open bite. She was barely touching on the last terminal molars without touching on any teeth. And so, as you can see, that the X-rays was screaming about a surgical approach. And that's no doubt that surgical approach was one of probably the best, let's say, solution. But she was telling us some answer. There was some complex aspect to handle with Julia. So there was 5 previous consultation on only on one direction: surgery, surgery, surgery press extraction, fixed appliance, a long path, um, sagittal and vertical dimension complex to handle. No one was even figure about using aligners, and no one was giving hope. But no one did study the case yet. So Julia asked, Dr. Carino, I understand that the idealistic in my case is a surgical case, but I don't not want to have someone broken my bone. So do we have a plan B? Despite we know it will not be the best case in the world, but I want to improve my scenario. I don't need to be the best case in the life. So, and then I thought, could we eventually think about a scenario where we could use this kind of approach with aligners and eventually this sagittal first approach to get to an outcome, also in terms of appliance for a 30 years old who was having who has a work in contact with public daily and daily. So she said, I cannot even think to go into a surgery room or wearing brackets because otherwise I will leave it like this. So we decided to do our records and ask a first virtual plan because she also was asking, can I use aligners in my case? So when I did the plan, and you will see that this case lasted 99 aligners, which is an insane amount of aligners. Yes, nice movement, sequential, correcting the sagittal, correcting the vertical, lot of the use of class 2 elastics, but is this really doable by a human being in Europe, in Italy, especially where you know that the Mediterranean are not like Japanese patient or German patient. So that was the big deal. Despite many movements were predictable, but some of the movement was less predictable. So I used this first virtual plan to tell her, look, this will be an endless case, despite the plan is proper. So sequential movement, distalization, and having just a simultaneous movement, and of course, a big change in terms of numbers. So which were the 4 dimensions to handle? Well, not only the sagittal, not only the vertical, not only the transversal, but in this case was time. So I thought, why don't we think about a virtual plan hybrid? And don't forget, in this case, we had upper canines blocked out. So in this case, I could not think about using the full motion appliance to get space for getting in a class 1. So we decided to ask for a second plan with aligners in the lower, asking for a diagnostic setup in the upper, to show me in one stage what I could do with another appliance, and then see, without making any promise, big promise to the patient, but at least, as you said, this should have been something, a plan B that could improve and at least allow us to chew. That was really one of the main aspects of the malocclusion for her, to improve the chew. So we decided to use the shorty ones from first bicuspid to first molars, having the sidekick bonded on the lower second molars. And I tell you, was a really diligent patient. So that was the treatment stage with the hybrid approach, with a short motion, 3D clear, lower aligners, buttons on 37 and 47, elastic protocols as usual, and once reached the class 1, swap the upper aligners. So after 6 months, I tell you, I was quite impressed positively about the amount of sagittal correction we got on the bicuspid and molar, considering the initial stage. I did not improve it yet the open bite, and I knew about that. But as you can see, we swapped it to a regular because we had a little bit of gingival recession on the upper first bicuspid. So I stopped it, used the shorty ones. That was a sign of a patient wearing using a lot elastics. And then after 8 months, we did from this point a scan for additional aligners. Where we have, once we corrected the sagittal, the main goal here now was to work on the vertical and closing all the gaps in the space and then correcting the open bite. So after 14 months, during additional aligners, that's a scenario that you can see from the 8 months, and after 6 months, this patient was having teeth touching each other, something that she never lived for 30 years. So that's her before retention. Just before we went into retention, as you can see, sagittal, transversal, and vertical was almost done. So this case is not completed yet. So I will see her in the next 2 weeks, and we will see if we will overcorrect the scenario or we will go into retention. But if you can imagine how she was, and you can see how she was, and now she has a totally different scenario, and also this is the lattice we did in progress. We will complete that open bite closure, but without sacrificing or using or breaking the bone, which is the main request of this lady. And this is the article that is not published yet, but you can see on the progress. So an angular orthodontist that they made a study about the comparison about the shorty and the standard class 2 career motion appliance, and it looks like the shorty one has the same effect as the long one. So it makes me also more prone on using the shorty one on adults because it's less visible than the one bonded on the canine. And what about teenagers? So I show you two examples of the use of this approach hybrid in a male and a female. One more, let's say, solid class 2, and the second one, a nightmare that became then a Millennium Falcon. So teenagers, as you can see here, the teenagers today can be nice teenagers, but also ugly teenagers. And this is one of was the ugly teenager, which was Mario. Mario represented a typical example of the teenager that you would never want to have because he was at all a nice guy. His father, who is a general practitioner, sent Mario to me because he said he want to have his teeth fixed and he doesn't want to have braces. He doesn't want to have lingual, nothing metal. He just want to have aligners. But once he came to the office, I said, well, look, Mario, we can fix this, but I need to have you a totally different attitude because I'm here to give you a service, but I'm not here praying to you on getting a treatment done. So as you can see here, he had a class 1 on the right side, class 2 on the left side, with a crossbite on the left side quadrant and midline shifted. He had the third molars present, both in the upper and the lower. As a general rule, typically I ask the extraction of the third molars if this can interfere to the sagittal movement of molars and bicuspid and canine. In this case, I follow that rule mainly because I want to make sure that this sagittal could occur quite quickly. And as a diagnostic summary, it was evident that he was a skeletal class 3 with a class 2 molar relationship, with a class 2 canine relationship, with a crossbite on the left side, and with midline shifted, with a mild crowding on both arches. And that was the most complex thing to handle because for Mario, that was his main concern. So the upper canine procline. That was my concern. My main concern was the class 2 to correct and also the crossbite to correct. And I have to think about which could be the order. So I was the man with a guessing point. So where should I start first? Sagittal or transversal? Sagittal or transversal? And that's why I was going back and forward thinking, where should I start first? And I tell you that before some years ago, what have we done? Let's correct the sagittal first by expansion and then go with the sequential distalization. But then I thought, why I could not revert the action? Because I have to think, if I'm asking to wear elastics, a class 2 elastic for not from the first 6 months, but later on, that will be not easy to handle with this not nice guy. So the strategy with him, and strategy in orthodontics is like being a good trainer in a soccer game, no? If you do the good strategy, then many times you win the game. But in terms of strategy, we can have different strategy. The important thing is we get to the same goal. So in this case, we decided again to correct the class 2 molar and canine on the left side with the motion, correct the lower crowding, and once obtained the class 1, swap to aligners on both arches. And within the additional aligners, correct the crossbite on the left side. So this was the clean check plan. And I tell you that with Mario, it was clear. I made the first clean check plan, and this was another endless clean check plan because we needed the first one I asked was to expand and then to distalize. But I had a clean check of more than 65 aligners, predictable. But what was not predictable was my patient not predictable. So then I had to explain him, and with teenagers is mainly the same story. If you explain them why you make a specific decision, and they are smart enough and they understand, and he was very smart and very intelligent, he understood by looking at the clean check plan, the first one, that was then a long path. So I said, are you ready for that? Or you let me go for with a hybrid approach, and then after a few months, we go into the aligner work that is your main goal. And we know that this is an aspect that many times we have to face, no? So the treatment stage with him was quite clear. Extract 28 and 38 before starting the treatment. So using the wrap effect, we put in the motion 27 on the left side, 13 lower aligners. For the first month, force 1 elastics, 1 4 6 ounces. From the second month until I got the class 1 and ideally even corrected, force 2 elastics, 316, 8 ounces. Then at the bond of the motion, I made an impression for a temporary exit retainer. You can do either with a scan, either with PVS impression, either with an alternate impression. You don't need to have a scanner, of course, but if you do an alternate impression, make sure to have delivered that temporary exit retainer within 1 maximum 2 business days. And then I did the scan for additional aligners. So he knew the target, and it's important that if this the cartoon in blue is your teenager, that he visualize or she visualize the target. So starting treatment, you see that I broke, as a good Italian, a little bit the rules because my mentor in this appliance, who is Luis Carrier, told me, Francesco, put always motion on both sides. But then I thought, why I should put on both sides? Is because you want to sell me one motion on the side where I have already a class 1? So what I did? As you can see, I bonded the buccal tube on the first molars because the second was partially erupted. I bonded the motion, the metal one, on the left side. And I said to Mario, look, if I see that while you're using elastics, we're losing the class 1 canine on the right side, I will put right away a motion also on the right side. If you want to be in the safe zone, you could put one on the right side and ask the patient to wear an elastic only at nighttime, just to make sure you have any kind of canter to occlusal plan. So this is the plan done after the extraction of the 28 and 38, when the motion was already placed. And he became a very big surprise for me because after 4 months, as you can see, on the left side, we had the class 1 molar and canine overcorrected by 1/4 of the cusp, which should be the main goal, because you have to think that you could have a minor relapse, but really minor, of the position of the canine. And then you saw the space opening mesial to the 23, plus midline centered between the upper and the lower, where at the beginning we had the midline off, the upper midline off by almost half the tooth. And so as you can see here on the right side, I bonded in the meantime a button, a lingual button to correct the crossbite on the first quadrant. And at that time I was still using buccal tubes, while afterwards I was using the sidekicks buttons. So just to make a comparison between before treatment and after the sagittal first effect, you see that we already corrected the sagittal, we improved the vertical, and we have to improve from this point the transversal on the molar region on the second quadrant. While already in the first set of aligners, we already improved the crowding in the lower arch. So Mario was a big surprise for me because he understood that having a visual goal was making him to what he wanted when he came to the practice. And I told you, look, we saw together that the first plan is predictable, but it's endless for you. So he understood this. So that's why he was able to get to the intermediate goal. So we got the sagittal goal, reach it, both molar and canine, improve the transversal a little bit. And one of the clinical tips I always recommend is to overcorrect the class 1 canine if you can by 1/4 of the cusp. So you see the difference between a class 1 and an overcorrected position. Ideally, go with the overcorrected because then you don't want to have the patient during the additional aligner stage to wear elastics also during the additional aligner stage. So I rather having this overcorrected position. So for the patient, he or she knows that there will be no need more for elastics. So the goals for the additional aligner stage were to correct the crossbite on the left side, to complete the crowding in the upper arch, and close the spacing in the upper, and finish the crowding correction in the lower arch. So it's important that you know and the patient know which are the goals for whatever stage. And this is the new 3D printing process we have now available with the iTero, because we can import a STL file from a scan that we did. And once we have imported this, we have a specific tool that allows us to cut the base, not using an external software, but we can use a specific tool that allows us to cut the base of the model, and thus reducing the amount of resin we need to print the model. So in that sense, is a very simple tool that allows us in really 3 steps to make sure we have a model, then printed Wi-Fi, and then have it, you see, trim it with a slider. You can move it. This will reduce the amount of resin and have a really thin model that you then print, and then on which you make your SX retainer. So that's a clean check plan of the additional liner, where we have 17 upper liners and 13 in the lower, where the main goal was now to close the gap in the front zone and then to correct the crossbite on the left side. And as you can see here, we at stage 12 of 17, the crossbite was improved. One of the things we adding whenever we have to correct a crossbite with aligners is to ask the technician to have a horizontal rectangular attachment with an extrusive force during the expansion, because you want to avoid having a tipping movement during this expansion movement. And that's Mario at the end of treatment, where you can see the same day, once we removed the attachment and then he went to the retention, of course, this minor fitting issue that we can have here in the molar region disappeared during the retention, because you didn't have any more the thickness of the upper and lower aligner present in arch. But as you can see here, on the sagittal, on the vertical, on the transversal, we improved, I would say, a lot the initial scenario. And we still have the 18 and 48, and we have to know what we have to do with these 2 teeth, but this will be something that will be evaluated during his growth, because he's still a mature teenager. The angulation of the lower incisor, just move it by a little bit more than 2 degrees, and I think that this is acceptable in terms of proclination. These were the facial changes before and after, and he became a nice guy, I would say. And that's nice also about our profession, that sometimes some ugly patient becomes a good patient. We know that the airways can be evaluated only by cone beam, but in Italy we have a strict regulation that we cannot do cone beam in a young patient, except that you have a reason, a reasonable reason to do an extra investigation. But this was a nice exercise as to see with a drawing if we have some airway change before and after treatment. And that's happened with this drawing, as you can see from the beginning to the end. But even most important, we also see the changes before and at the end of treatment. Also, how we intruded the initial position of 13, which was over erupted. And also, we have two canines in the upper arch, which were much more even than from the beginning. We have the midline centered between the upper and lower. We have the sagittal correction obtained, and we had the transversal correction reached. And even more important, how is Mario now 24 months in retention? And as a retainers, he using a Vivera retainers, which is the Invisalign retention system. As a general rule, I rather this kind of retention in my patients. Sometimes I'm using fixed retainers when the patient is not ready anymore to comply in retention. And in those cases, I'm using a fixed retainer, a digitally driven fixed retainer named Memotane. So just as a summary of this first teenager case, he lasted 4 months with a hybrid approach, 6 months with additional aligners, and 10 months on total treatment time. So remembering one of the first slide where I said the Gen Z patient, they're aiming for a year of his orthodontic experience, Mario went into 10 months of active treatment time. Alberto is a second example of teenager that I want to share with you because Alberto, when he came to the office as 16 years old teenager with a class 2 dental with crowding and midline shift, he came like this, and which was the main issue? That he was already in treatment and treated with aligners in another country for more than 3 years. So you can imagine this, the mother and him was not happy at all by the result obtained with the previous treatment. And I have a class 2 a class 2 to handle. So I have two options, and this guy was really depressed in terms of motivation. So I have to be able to remotivate this guy very quickly. And of course, one of the options could have been aligners. Again, do a virtual simulation using brackets, whatever. But I have to be very honest with him, thinking if this was my son. So with Mario, I was very honest and clear with him directly. I told him, look, I understand that you spent almost 3 years with the previous ortho treatment without in your best age and without any and with aligners, without any good result. But this was the strategy we had with him. So also for him, I thought probably the hybrid solution would speed up one of the main goals, and then he can ride his, let's say, nice appliance later on while I'm starting to correct the crowding in the lower arch. So that's why we had the first clean check plan with the sagittal first, the diagnostic setup in the upper arch, where the technician was showing me in one stage what I will do with another appliance. So you don't have to mention to a technician what kind of appliance. They don't care. It's important to know the goals. While in the lower, I really minimum to do. I could have used a ASIC retainer in the lower as an initial stage, but I thought it was better to start with using aligners both in the upper arch and to start also giving some more motivation. And if you look at start treatment, we bonded in this case. I made the same agreement with him as I did with Mario. So I bonded only on the right side, the motion. But having in mind that if we lost a little bit of full class 2 on the left side, and in fact you saw I bonded a sidekick, a button on the lower first molar, if I have this scenario, I would have bonded a motion also on the left side. So this is the configuration with the lower aligners, with the elastic bonded in that I sent to him by email. And that was really surprising me that after 2 months, considering this initial point, after 2 months, um, Alberto was already getting a part of the treatment done, a part of the goal of the sagittal done. And that was him after 3 months. And what happened that he skipped one appointment. And look at here, I could have been scared, so no panic. I got those spaces opening, which was a natural consequence of the sagittal correction. So I had the upper midline at the beginning was off to the left, and now it was off to the right side. So what did I did? I did not remove the device just to get new aligner from this point. I left 2 weeks without elastics, and then as you can see this from this scenario, after 2 weeks from this point, I deboner the auxiliary device, and then I continue with aligners. So that was seen before treatment, and at the end of the sagittal first phase, where I overcorrected by 1/4 of the cusp the position of canine, bicuspid, and molars, counting that a minimum of relapse could happen. But once you have the upper canine touch the lower canine, then you don't have any kind of additional relapse. So that's one of the key when you dealing with this kind of approach. So this was the clean check plan we had for him with the 14 aligners in the upper, and we asked for the simulation. In this case, I asked a technician to place a 2 precision cut on the upper first bicuspids and a button cutout on the lower first molar in case I needed to use a class 2 elastics at night. So that was like a backup plan I wanted to have in my appliance as a safety net. So that's what's seen during the additional aligners. And as you can see, the midline are centering, the crowning is corrected, the sagittal is improving, and that's him before the final touch-up, where here at the final touch-up, what we have needed also to ask, we needed to ask our general dentist also to reconstruct the cusp of the lower first molar, which was grinded up because he was very nervous. So he was clenching and brushing a lot. So as you can see, before the final touch-up, this was him at the end of the ortho treatment, before going to the restorative dentist to rebuild the cusp of the lower 36 and 46. And one of the most important thing I like every time I'm dealing with the virtual simulation is also to have a comparison between the clinical and the virtual to let me understand if that plan that I planned was predictable or and I reached this and that's always a lesson for future cases. So this is the comparison before treatment, at the end of treatment, before going into retention, and in this case, I did not ask it a retainer for my line, but I waited to have the restoration done, and I just have to wait. This is finished by him. And these are the X-rays before and after, with the third molars still present, but he's a teenager. Then we will evaluate this over the next years. And in that sense, for him, we have 4 degrees of a reduction in terms of proclination of lower incisor compared to the other ones that we saw before. That's him after 18 months. He still did not make the restoration of the lower first molars, but I'm just waiting until he will do this job by his general dentist, and then he will go into a final retention with Vivera retainers. So this is another article that has been published, not yet official, but you can see on the Angle Orthodontist on the coming soon on the treatment effect of the carrier motion for the correction of the class 2 malocclusion in adolescents, still done by Jim McNamara and his group as an efficient, as you can see in the conclusion, as an efficient and effective way of correcting class 2 malocclusion. So when I see Jim McNamara stating this and Lorenzo Franchi, which are two super important orthodontists in our field, that's also giving me even more, let's say, confidence in using this kind of approach. Rachele, I show you 2 boys, but I also to make a comparison, I have to make also the same thing for teenagers, girls. So this was one of my first cases with a really mild class 2 relationship, both on left and right side, with some minor crowding, some deep bite. And she was, as you can see, the X-ray was done in another city. So she moved to Torino. As you can see from the diagnostic summary, we had a skeletal class 2 with a class 2 molar relationship, and canine with a protrusive maxilla mandible with deep overbite, excessive overjet, and mild crowding on all arches. So again, is some many times it happen that patient has some concern, and these teenagers, they are very demanding. I don't know in Russia or in Belarus or in other countries in the East, but that was her concern. This was my concern. So she was asking for aligners. That was her and her mother's. Um, these were the strategies. So to correct the class 2 molar and canine on the right side, to create space to correct the upper anterior crowding, to start correcting the crowding in the lower arch, and once obtained the full class 1, swap to aligners on both arches. That was the sagittal first clean check plan, where we got 14 aligners in the lower, the sagittal first simulation from the technician after the first clean check plan with the aligners. So you can also start from scratch in your prescription form to ask aligners in the lower arch and a diagnostic setup in the upper. And it's important if you go from the beginning with this kind of approach before even seeing a first clean check plan, then you have to specify in the special instruction that you will perform this with one another appliance. Don't specify what kind of appliance. So she started and she was very demanding as a young teenager. So we had motion left and right, canine to first molar. At that time, I was still using buccal tubes on the first molar. Today, if this case will come today in the office, I will bond for sure the sidekick on the lower second molar and having probably the short motion on the first bicuspid and the first molar. So after 5 months, we came to this point of the end of the sagittal first phase where we overcorrected the position of molar and canine. We got those spaces in the front, and this was how she was changing in this from the beginning to the end of the sagittal first. And that was a clean check plan, forecasting 22 upper aligners and 11 in the lower, with the space closure, the retraction of the upper with the presence also of the power ridges, with attachment placed by the technician, with a couple of complex movement in the lower arch. But this is how it ended up virtually, and that was the goal we had for Rachele. As you can see here in the lower, we have that minor crowding to fix, and also we have to improve that the teep height. You see that there's the black triangle between the upper two central incisor, and this was something that we were deciding to not fix within this virtual plan. We will decide at the end of this set of aligners if we will see our clinical black triangle or if it's only a virtual black triangle. So that's our in progress, where we see that we keep in the sagittal relationship, we improve in the space closure, and that's her at the end of Act 3. Just the same day, we debonded the attachment and we asked for retainers. And so during her retention period, so this is the comparison before and after, you see that the sagittal correction happened both on the left side and on the right side. We improved the vertical, we improved the transversal. Also the gingival, the margin in the upper are improved due to the orthodontic movement. And that was a comparison with the virtual, so the clinical and the virtual plan. And the same was done with the virtual of the occlusal in the upper and the lower. So that's one of the, let's say, thing that I like always to share, not to tell to my patient how good I am, that I don't care about this, but also to congratulate the patient for the nice job they doing in being compliant. And especially for a girl like this, you see that before and after, we reduce it consistently the excessive proclination of both upper and lower incisors. And we have 2 degrees, 0.2 of a reduction of the lower incisors. So we pass it from 102.5 to 100. And that was her before and after treatment. So the smile improved, the profile improved. And that's even more important for me is the 30 months control after the active treatment. So for me is important to see how there is a very nice adaptation with a good control, the vertical control, the transversal control, and the sagittal control, no presence of any black triangles, and in a patient where we have now the third molars slowly erupting and that we will control overall. So this is a scenario that I like it on those teenage cases, see controls at 18, 24 months, 30 months after the active treatment. And this is the article on the angle orthodontist that you can find online, which is an open journal, about also the evaluation of the adolescent and adults treated with the career motion, followed by fixed appliance. That's another scenario where you can handle a first part of the treatment with the sagittal correction, followed by brackets. So there is not only one way of dealing with this class 2 hybrid approach. You're seeing this evening different scenarios of adults, teenagers, male and females, but think about also how you could embed this kind of approach in your practice with the tools you have, whether it could be aligners, that could be brackets, or could be lingual, for example. So in summary, also Rachele uh, became a patient with those kind of approach. So 5 months of sagittal first approach, 5 months of refinement, and 10 months of treatment time. So the third category of a patient that I was curious to see if this kind of approach could work was early mixed dentition. It could be a solution efficient and effective, and that was imagine that Bart and Lisa are going to the dentist and they are around 8 years old. I would just tell you a small story about this other patient that regarding to categories of potential worst patient you can have. We know that parents could be one of the worst patient, colleagues, you see Mario, the son of a colleague, or friends. But I found one category which is even worse of these three, which is your new neighbor at home. And that's the story of Daisy. Daisy, 8 years old, moved with the family from UK to Torino, and she lives in the same building I live, but not even more only the same building, at the same floor. So when I opened the door in the morning, I met once the parents, and I met Daisy. So after some months, they asking me, they were Italians, they asking me, oh, we would love to bring you Daisy at the office because I can say, "Okay, smile, Daisy." You see, she has this smile, this gap between the center and inside that we don't like. So can you do something? And and they also told me about an episode of Balism that she had in UK, and that's a fact that we have to face in this decade about Balism and many episodes also on social media. So that's a fact. So they asked me, they told me about this episode, and this was related to the fact that some kids at her age was making joke of her because of her spacings and not good smile. So they asking me, okay, and this is another article that has been published a few years ago about Balismia, but we know that this is became booming on between teenage, but also on kids in the recent years. So when she came to the office, the space between the upper incisor was the least problem I have to handle because I say, well, we have other issues here. We have a class 2 on the right side. We have a crossbite. And yes, we have that space. And we have a 22 severely rotated plus midline shifted. So I did the records for Daisy, thinking in mind I cannot make mistakes in this planning because that's my neighbor. So if I make me imagine a nightmare, if this case went wrong, I should move from my apartment and move to another building. So um, that's a diagnostic summary of Daisy, who is also a skeletal class 3, depending on width, skeletal class 1, depending on APO, with a class 2 molar relationship and class 2 canine relationship, with a crossbite on the right side, with deep overbite, with an excessive overjet, and with mild crowding on both arches. And again here, the main question, where should I start first? Sagittal or transversal? Transversal or sagittal? And it took some time to decide because I have to count the good point and the bad point. Yes, I could have put an expander here, but they asking me, oh, can we think about something less invasive than an expander? because they have this suggestion in the UK to have an expand, which could be an option, of course. So that was a guessing ahead. Sagittal first or transversal first? Both options could be good, of course. There was no point about this. But I made a decision to go sagittal first, always keeping in mind if I need compliance, I want to keep the first month where the patient is very eager on being compliant, then on the later on, once the patient is maybe not that super compliant. So this was a straight strategy for her, where we decided to correct the class 2 molar and canine on the right side, to create space for the upper laterals that have no yet too much space, center the midlines, start correcting crowding in the lower arch, and once obtained the full class 1, swap to aligners on both arches. And once correct the IP discrepancy, correct the crossbite. So the treatment choice was lower aligners and upper motion for 3 reasons. Shorter treatment time on class 2 elastic wear, less risk in terms of compliance, and also a minimal invasive orthodontic strategy. So that was the clean check plan she had. And I remember when I told you before in the protocols, in this case we used force 1 elastics, not force 1 and force 2, because of the fact we're working on deciduous teeth. And remember, in this case, we were having at least 50% of the root of the upper deciduous canine present. Otherwise, we have to wait or decide, or we could have swapped it in the plan and expand first and then work sagittally. So that's how she started. And as you can see that already after a few times, and at that age, teeth, I will say, flies. They fly. So you have to be very careful on timing. And within 4 months, the sagittal issue was mainly corrected on both sides. We overcorrected in purpose, as you saw in the case before. And she knew that those gaps will open a little bit more than from the beginning. Is she aware about that? And from until this point, I didn't care about the transversal because this will be something that I will address in the next step. So here you have to be careful. That's another clinical tip. Whenever you're removing the motion 3D in kids, it's better to remove it a bit with a high-speed burst, some small amount around the canine pad, and place in the patient mouth a cotton roll. Ask the patient to bite. Use an old ligature cutter. Remove the motion twisting on the base, and then roll the motion from the canine until the molar. The following step planned to the both motion, provide a temporary S retainer on the upper arch, and make a new intraoral scan for new aligners to complete the phase 1. And that was a clean check plan for additional aligner, where we were addressing at this point changing aligner every week and having those attachments which were helping to correct the transversal, completing the rotation, and in purpose having spaces mesial/distal to upper deciduous canine to allow enough space for the eruption of the upper permanent canine. So those spaces you see on the virtual plan are planned in purpose because we have to think about this patient ending then a phase 1 treatment and then eventually having a phase 2 later on. So that's her during the additional aligner stage, where she improving the transversal on the right side through a book dental velar movement. And that's her at the end of the aligner stage, where you can see we had the spaces mesial to the upper C that we planned during our virtual plan. That's our X-ray documentation, where you see we have now enough space for the erupting teeth. Just 2 degrees of increase of the proclination, keeping in mind we used force 1 elastics only at that with this patient. And that's how she changed this profile, of course, as a profile and smile change. And I see daily now, Daisy, every day when I go to the office and she go to school. And that's nice to have as an experience. Emma is the second case I want to share with you as a kid, in which you could think about an for a hybrid approach. This young lady came to the office with a severe deep bite, with a lack of space for the upper laterals, with a class 2 on both sides, and with a lack of space also for the 42. So, and the panoramic X-ray was showing us lack of space, definitely. In a normal to a brachyfacial patient, so ideal ones to start with this approach. This is the diagnosis summary of Emma. Um, the main point for her was to recreate space for the laterals, to improve the deep overbite. She got mild crowding on both arches, and she were in early mixed dentition. The smile was not nice, I tell you, and this is one of the complaints that the family has. And when we're talking about aesthetics, typically for many years we spoke about aesthetics in adults. But what about aesthetics in kids? We have to be aware that aesthetics in kids is important. And why we always to think about adults? Kids, they look at each other. They deserve to have also a nice smile already from the beginning, not to wait until 12, 13 years or 14 years. Why should not think about this? Also, taking in consideration all these social media and social and where we're living in a selfie generation, not the kids, but but many times teenagers live in a selfie generation where they look at a lot about the front. So here we thought that this hybrid approach could be very helpful for her because we could correct both the sagittal at the beginning, create space for the upper laterals, center the midlines, slightly correct the crowning in the lower arch, open the bite because she was a deep bite, and once obtained the full class 1 and reach space for laterals, have a new scan. So it's always about strategy and planning. So the clean check plan that was made from the beginning with her was a clean check plan with a clean check plan having these goals. So in the lower arch, open the space for the 42. So you can see a pontic, a period in the lower arch, while in the upper we ask it to simulate in one stage what we will do with this other appliance. So it's important this also to share. That's why I always recommend if you're planning, if you have a doubt with an aligner solution or maybe a hybrid, ask for the aligner solution first so they understand the sequence of movement and then ask for the second solution with the sagittal first. Otherwise, it will happen, and it happened to me in the past, that the patient will ask you, oh, but how can you get to this point with this single step? So if they see the sequence of movement with, let's say, where you're moving all the teeth, then for them it's more understandable at the chair side. So, and when someone is asking me about which is the best patient to deal with, is an adult, is it a teenager, is it a kid? I can tell you that my favorite patients are this patient, kids. Young kids, girls are the best patient for me, at least to handle, because the key is that to involve them as much as you can from the beginning, explain them, also through an intraoral scan, explain the goals, what you're thinking to do, because if involving them, because they have to wear the appliance, they have to wear the aligners. It's not the mother who has to wear the aligners. So if they understand the goal and you show an example similar to them, they will be the best patient in town. Very excited because they also have a cool appliance. Adults is always a complaint. And if you think adults are serial liars, teenagers is also a question of there are some teenagers who are it's better not to talk about aligners because the compliance level is 0, so it's much better to put a fixed appliance. But anyway, you will need, if you have a class 2, to ask them to wear elastics and let you put tats. But what is important to hear, to see, is that while we were working sagittally, we were creating space for the 12 that you see is coming a little bit and erupting while we're creating the space. And at the end of the sagittal first, you see that we overcorrect a little bit the position of molars and baby canines, while the upper lateral incisors were erupting. And also we got more space for the 42. One small side effect you could face, like in this case, is if you have a patient very eager on wearing elastics, you can have a mesorotation of lower first molar. This is something that you can counteract, and I learned this over the time on putting the button more distal and putting an attachment on the mesial cusp of the molar. So making sure you have this aligner that in fitting in place, and you don't have this minor side effect. Also because we have a bone density much different than in a mature teenager and then you have an adult. But what it was impressive for me was to see how also the bite was opening. And that was one of the effects that Jim McNamara delivered in his publication, that this appliance is opening the occlusal plan. So in the ClinCheck plan for the additional aligners, you see, and here I had the doubt, should I start now or could I wait it an additional month? If I did not have those lower first molar mesially rotated, I probably would have added an additional appointment and then waiting to have a more eruption of the lateral incisors. Or to leave the patient to have elastic only at night, wait a month to have the 22 more erupted, and then swapping to additional aligners. So you see that here the technician created a virtual plan with two horizontal rectangular attachment because we have a short clinical crown here. The main goal was to extrude these lateral incisors, derotate the lower first molars with the use of this optimized attachment. While in the upper arch, you see here that here we have just to complete what we got with the space we obtained in the first set of aligners. And here also we had those attachments we were completing this first phase one. And that's our in progress, where you can see that now we have the upper lateral incisor in a much better position. We have an eruption compensator on the 42 area that we will then we will follow up with new aligners once we have open a bit more the space and then allow the eruption of the 42. So that's at the end of the phase one, where mainly at this point where we have enough space for the lower canines, enough space for the first bicuspid, second E, lower E that need to exfoliate. From this point, where we have the sagittal corrected, midline centered, the transversal improved, from this point, we can think just to put the patient on standby and leave the patient until she complete her full exfoliation, and once she have all the permanent teeth in arch, evaluate if we will need a phase two or if her orthodontic history will just be limited to this phase one. So, but at this point, also the case of Emma was a case that you see how the profile changed, and these are the important changes that we found out over the time before the treatment at the end of phase one, where we corrected the sagittal, the transversal, the vertical. You see there are some upper D that will exfoliate soon from this picture, and how we improved the transversal also in the lower. So now we have almost all room for the permanent teeth that will need to be erupted. Big guessing point was this in this case, what if I left this case with nothing? What if I did not treat this case? And that's sometimes the guess you have when you're dealing with the 7, 8, 9 years old kids that come into the office. If she did not have that deep bite, if she did not have this missing, early loss of the decidus lateral incisor, I will probably waited until I have the full permanent addition. But I want to avoid to have this young lady, a young kid, to spend maybe 2-3 years and having the bite worsening and having probably this case ending up in an extraction solution. So, and I wanted to avoid having these upper baby teeth, the upper canine, first molar and second molars moving easily, so then closing the gap. So that was something I have to, that was a decision we made to do with a phase one with this kind of hybrid approach. And this is the X-rays before at the end of phase one. You see now at the end of phase one, we have room for the exfoliation and the eruption of the canines of the first bicuspid and on the second bicuspid, and also room. Maybe she will not need a phase 2 or a limited phase 2 for just a minor defect in the rotation, maybe of a couple of bicuspid. And now I'm following up with Emma since almost now 2 years, and she almost at the end of her dentition, and we will see if and when she will need a short phase 2. This is now an article that had been published on the Angle Orthodontist in 2020 about a CBCT evaluation of the effect of the dentition. And this article concluded that CMA corrected the class 2 malocclusion through a distal tipping, rotational movement. So you see how much the rotational movement is important, both on canines and molars, and corrected the mesial tipping of mandibular molars. So, and the incisal flaring was observed in some of the patients, but that's always depending on how long you were in these elastics, and especially if you're dealing with the teenagers and kids, and you are overwhelming the force. So, just to conclude, and I hope that this almost these 2 hours of talk, and I know that is not that easy to stay almost 2 hours in front of a computer to listen to a speaker, but I try to make it a mix and match between theory, clinical tips. Some of the consideration I want to share with you about the hybrid approach in class 2 is consider to evaluate the use of auxiliaries before or in combination with aligners, but also thinking about before or in combination with brackets or both buccal, both lingual. It's not only one way of dealing or treating cases. Maybe some of you will use aligner, some doesn't. But if you're thinking to using aligner, think about patient compliance if the virtual plan is too long. Despite the virtual plan is very predictable. I don't know in Russia, in Belarus, in other Eastern Europe countries. I know in Italy can be an issue, compliance, especially in adults. And this kind of hybrid approach that in this talk was especially with the use of a motion 3D, but could be whatever kind of a class 2 corrector, again, a pendulum, a distal jet, whatever kind of class 2 corrector. This provide a dental alveolar correction, not a skeletal one. The good point about this kind of approach is that you saw by cases, and these are real numbers. You didn't see every case 6 months, 6 months, 6 months. Some case lasted 4 months for the sagittal correction, especially on a young patient. Gabriele took 7 months, 7 months and a half, because at the beginning he was not that compliant, or maybe at the beginning I was not that eager on telling how much they should wear the elastic and how much frequently they should change the elastic. So in that sense, it's very important the full-time elastic wear and force level is one of the key aspects. And in fact, I remember last year it came out on the Kevin O'Brien blog, some haters, some lovers of like everything, no? But one important thing that the inventor stated, he never stated that this appliance provide a skeletal effect, never. And Kevin O'Brien stated that if this device is a device that, with the use of elastic, with heavy forces, provides a class 2 correction, I agree with that. So already a very critical Kevin O'Brien, he was agreeing that this appliance have this effect. Of course, the device itself is inactive if it's not activated. It's like having the best series of brackets you can have in the orthodontic community, but without having the proper wires. So I always recommend that do not stop at the first solution. Use the power of virtual planning. We live in an era where kids, teenagers, and adults, they want to see. Today, I had a patient who came in the office and he asked me, "Oh, is my case can be treated with aligners?" Just 3 hours ago, and I said, "Look, I have to first see your case. I have to see which are the issues." And he got a class 1 on one side, a class 2 on the other side. I say, I have to study the case and evaluate based on possibilities of the system, your compliance, and my skills. What is the best appliance or the combination of two appliances? Someone could tell me, oh, but if using two appliances, that would be more expensive. But I will revert the question and say, isn't it more expensive to have a patient too long on the chair side, so you're spending too much time at the patient at the chair instead of maybe adding maybe an additional 100 euro, 200 euro for this extra device, which can be a pendulum, a distal jet, or whatever class to corrector. For me, is important is to deliver an efficient and effective solution to my patient and to be very honest with them. So that's I started telling about the nice of our profession that can allows us to have a different solution for similar goals, and that's why I'm very curious. I have the luck of having patients dealing with aligners only with a sequential digitalization with 50, 60 aligners, and they are going on nicely. They're wearing elastic, but not everybody can do this work because they don't have the same strength in compliance. And we know that if we just let's say put on the table one solution or two solution, and we honestly talk with the patient, which could be the best one, but of course based on facts, not on metropolitan legend or thoughts. This is always is a good start of the relationship between us and the orthodontic patient. So I hope that with this take-home messages and with this, I hope the global view you got with some clinical tips and technical tips that are always useful to deal with, that you bring something home. I always say that when I'm lecturing, if a colleague is bringing home at least one tip, I'm already happy. If there are two tips, okay. And that's the same when I listen to some colleagues, when I learn one thing or two, that's already for me rewarding. So say that I thank you so much for your attention. I see Arrivederci and Dobre from my city. That's the view in the evening from my city. And so if there are any question, I think that now is time for opening question time. So the team of OHIS, which I thank so much for all the support, for all the technical, everything went well in the testing. So I hope also the live event went properly. So I'm ready for the questions. So if there are questions, I hope, and so I leave some minutes for the team to write out the question, and then I will get them the question that I hope I answer by the time. Oh, good. Okay. Let me just read the question and then I will. Oh yeah. So there is one question of. I know my friend Dr. Garino. I know you are one of those early using class career for class 2. Would you show us also the use of class 3 cases and your protocols? Well, the topic was class 2, my friend. So I hope that maybe in the future we will talk also about class 3. But I can tell you that the majority of cases I dealing is class 2. So maybe in a next webinar, we'll also deal with class 3. But if I can just give you a first hint, with class 3, you have to be to know that there are some limitation. Of course, is a dental velar compensation. So some cases you saw, for example, the case of Julia before, that was a borderline case. And the cases I dealt until today, there are a couple of probably surgical cases that ask for a plan B. And the protocol in this is but there is no time to go too deeply in that question. But typically, I'm using aligners in the upper and then motion 3 in the lowers with a force 1 elastics. And it's working well. Of course, depending on the discrepancy you have in class 3. So the second question is, so do you suggest that if we use Carriere, we should also use the Carriere? Yes, it's not a suggestion I give because I like the freedom for everyone. But when I read McNamara publishing and showing me these numbers, that's for me a witness that someone studied at the university in Ann Arbor, in Michigan, the strength of these elastics. So personally, I'm not using other elastic I have. I tried to do as a good Italian years ago, but I found out that using those elastics are much more efficient than the other ones. And how important do you think is the cost of the career, especially a transparent one? What are the different prices we get in Europe? Well, the price of the career, I'm not here talking about pricing, if you don't mind, but in generally talking, the clear one, it costs, at least here in Europe, it costs about between 100 and 150 euro, and depends on the discount you got from your distributor. But that's not the price that it makes me scary, because for me, it costs me much more to have a patient sitting on the chair side, maybe 3 times more than the cost of the device. Um, then does extracting thermal help with the career? It helps. I always said, as I said also before, for me, the rules are that if the third molar will interfere or not allow the sagittal correction, I will extract the patient to extract them. If those third molars are still high and distant from the second molar, I will not ask them to extract them right away, and eventually I will ask it to extract during retention. Do you have any extra problem when using a unilateral carrier at the upper arch? No, I did not find extra problems. If you want to be in a super safe zone, put motion on both sides and ask the patient to wear elastic only at nighttime where you have a class 1, and then while on the class 2 side using day and night. But as you saw in those 2 cases on a teenager, uh, I said to the patient, look, I will start on the class 2 side with the motion, and if I see that I can lose eventually a minimum of class 1, then I will put the motion on the right side. I like the fact that in the patient with small laterals, we get the extra space. We need medial and distal to lateral. Thank you. Yes, this is something that I like too, because for me, gaining spacing for laterals is very important. And you saw also the case of Rachele. She was planned in the clean check to make 2 restorations on the 2 lateral incisors, which was a little bit smaller due to a minor bolt-on discrepancy. But at the end, there was no need clinically for these restorations. Do you know what is funny? After listening to attending 100 webinars with top speakers, half say sagittal first and half transverse first. Poor me that I'm trying to decide when I have less experience than them. No, well, but that's a good point. That's a freedom of our profession. That and I tell you that before using sagittal first approach, I was doing transversal first in all my cases. But when I started to use this appliance, and you see, the reason why I wanted to give you different vision on adults, teenagers, and kids, it's a question of is it efficient and effective that to do the sagittal first, because again, I'm reducing the double compliance, so elastics and appliance for less than 6 months, and then the patient is riding on his sailboat. Otherwise, if you're working on transversal first, and then after 6 months telling now you have to wear class 2 elastic for a year, that could be danger. And I always thinking, if I was a patient, if I was a patient, I'd rather to sacrifice for the first 6 months than later on. This is something that not every orthodontist is thinking. I personally was a patient 30 years ago, so I know what it means to put an appliance. So if some of you went into the orthodontic treatment know what I'm saying about, probably many orthodontists did not had a direct personal experience of wearing an orthodontic appliance. So it's okay to have, you're not for you, but I try to show you scenarios where in my let's say my hands, but not only my hand, many clinicians, it's a good point, but you will see by experience, it's good to have the solution, to visualize different solutions. That is basically you try 1 case or 2 cases, and then you will see if this will be efficient for you and your practice and your patient. Uh, 2 hours in front of PC, it's easy when the speaker is you, and don't forget we are the old generation, we can last all. Yeah, you're right. Well, first of all, thanks a lot for the compliments. As you can see, I bring a lot of passion in my work. I try to deliver all my secrets, because there is no secrets for my colleagues. For me is it's a pleasure to really, for those of you who knows me, I like to share. I'm not jealous of the things I do. I like also to show you what could be the potential issues and how to overcome the minor issues. Um, One more question. Do you use motion on lower jaw to upright mesially inclined molars? Uh, no, I haven't used motion to upright inclined molars. One thing that I doing right now, you know what, is I'm using a motion in the upper arch, the regular one. So I started in two cases, two new things, just to give you the latest one. Um, I I'm using in some cases the regular motion from 4 to 7 with the side kick on 7. So then I'm not moving I'm not touching the canines and let the transeptal fiber moving backward the canines. And the second thing I started to do now recently, and I have to admit I saw this done by another colleague in Italy, I do the clean check plan, upper and lower, and while I'm correcting the motion, the class molar relationship on the right side, if it's a unilateral class 2, I'm having the aligners in the upper from the second molar to the lateral incisor. So I'm starting to moving teeth on the upper arch on one side while I'm correcting the sagittal on the other one. So these are the two latest things that I'm working on.